This clinical trial, it's a phase 2 single-arm study of guadecitabine, which has been previously used in other studies for frontline therapy in patients with high-risk MDS and CMML. And so far, the objective is to enroll a total of 100 patients. So far, we've enrolled 50 patients in total, and with a median follow-up of 6 months. The overall response rates we have observed are 71%, with 32 complete responses, also in patients with CMML, and these were all patients with very high-risk disease, so close to 80% of them had high or very high risk by APSS revised, excess blast, 42% had complex karyotypes, high frequency of p53 mutations. So even though the median follow-up so far is short, and we cannot really see and assess survival outcomes thoroughly, but the responses are being quite impressive, so very high rates of response with few toxicities. Most patients had just grade 1 or 2 adverse events or neutropenic fever, which is obviously common with other hypomethylating agents. But even though it's still very preliminary results, we feel like this could be encouraging in the frontline setting of very high-risk patients.
And would any clinician watching this be able to contribute patients to enroll here?
Yeah, absolutely. They could contact us, and the study is open at MD Anderson, so if they feel they want to enroll patients, that's a possibility. And there's also a phase 3 trial ongoing, which is multicentric, for patients that have been previously exposed to hypomethylating agents. So there's several potential clinical trials on guadecitabine for patients with MDS, but yeah.
And then switching tack quickly to azacitadine and vorinostat.
This clinical trial, even though the combination of vorinostat was elected, the objective of this clinical trial was not really to prove whether that combination is superior to single agent. The way this study was designed is because normally we know that most clinical trials exclude patients with a poor performance status or with organ dysfunction or comorbidities. And we know that these subset of patients with AML or MDS have a median survival of approximately 60 days even treated. So we felt like these are patients that have high stakes of potentially benefiting from therapy and have unmet needs. So that's really the objective of this study. And we initially enrolled 30 patients with MDS and AML with these features, and they received combination of azacitadine and vorinostat. And the primary objective was really survival at 60 days, because we know that's the median survival of these patients. And 85% of the patients survived that further from that threshold, with no major side effects except for grade 1 and 2 fatigue and nausea, and neutropenic fever was the main grade 3 adverse event, which we know is common with other hypomethylating agents. So there was no excess early mortality. Mortality at 4 and 8 weeks was 10 and 20%. For patients we know that have a median survival of 60 days. So in view of these results, we then extended the study to treat another 79 patients. And these could either receive azacitadine single agent or azacitadine vorinostat. And again, the objective was not really to prove superiority of one arm versus the other, because the study was not designed and did not have the potency to do this. But it allows us also to increase the experience and see that for sure these patients can be treated within a clinical trial in a safe manner. So maybe using other clinical trials similar to this with low intensity therapies, we can increase the treatment options for patients with poor performance and high clinical risk.